So I think we are now dropping into a chit chat. So Robin, I had discussed this before as well. Of course, this particular message from Pfizer was, or from the FDA, was shown as something of a underhanded game by them. But if you hear what they said in the court, what they said was, we only have 10 people who are responding to public Freedom of Information Act queries, and they are already overwhelmed. And if these 10 people will work on 300,000 pages, they could do, I do not know, they said some few hundred pages per month. And based on that, that would take 75 years. And I had made this comment before as well. Fine, this makes sense that an organization says we do not have enough resources. However, their response should have been, we're going to ask Pfizer to support it, or we're going to need more budget, and we are going to route that budget to this, or we're going to request that budget for this, or we are looking for volunteers who can come help us with this, and they can do security clearance on that them and do a volunteer work. We are in exceptional times. These are not normal times, so exceptional things can be done at this time. And so just simply saying that, hey, we'll come back in 75 years is not the best of the approach. This also tells me the lack of interest by the leadership to try to solve a problem. Instead, they just put the problem in front of the world and said, oh well, this is how it is. So Xenia says, Israel study and chit chat. So let's do this. I'm going to look at that study with you. So today you would see that if I am not actually fully prepared about a study, I have not read it before, then how do I fumble through it? So, so we're going to go from there. Let's see where that study is. I believe here is a study. So this is a study. I am going to present this separately to you later on as well. And my camera, I see that the person who came in for the work, he has made the camera a little misaligned. Anyways, I hope it is all good. Let's start. Let's look at the study. The study says SARS-CoV-2 Omicron has extensive but incomplete escape of Pfizer BioNTech elicited neutralization and requires ACE2 for infection. So this requires ACE2 for infection, we all know already. They confirmed it. That's not a bad thing. Part of their test was they confirmed it, and good. However, this extensive but incomplete escape of Pfizer BioNTech elicited neutralization. That is interesting. So, a couple of things I want to put in front of us before we look at it. And this is how I was thinking about it as well. So, it's not that I just want you to be thinking that way. I was thinking that when we are looking at the study is going to say, well, the Pfizer vaccine didn't work very well. But at the same time, look at the virus's behavior too, that it is, so far, the data says it is not causing serious issues. That means just as it is able to escape the immunity, it is also not able to cause so much pathology either. So it has done some changes accidentally to it that has made it more human friendly. And in that process, if it has become a little evasive of the immune system, then so be it. Maybe this is why the immune system is not getting mad at it, that it is not very avidly binding with it. Because if it is escaping the antibodies, then it would be escaping some of the immune system's responses as well, for example, T cell receptors or B cells, IgDs. So that is in the back of my mind. And now let's see. What they're saying is, and this is from South Africa as well, and for Professor Dr. Trens Komal, I am so sorry I am stealing your thunder, because you are the one who sent it to me and said, let's talk about it. And here I am, and this is just me. We would do a deeper dive with Professor Komal separately. The emergence of Omicron in November 2021, South Africa raised concern that based on large number of mutations in the spike protein and elsewhere in the virus, this variant will have considerable escape from vaccine elicited immunity. That was the concern. So, what they did was they said we investigated whether Omicron escapes antibody neutralization elicited by Pfizer BioNTech. So, that is what they wanted to test. So, how did they test? They said we used a human lung cell line clone, H1299ACE2, engineered to express the ACE2 receptors. So, they took human lung tissue cells, which were further modified to express ACE2. And then they, of course, acquired virus from someplace. And then they said, we observed that Omicron infected the ACE2 expressing cells in a concentration dependent manner, but did not infect the parental H1299 cells. So those original H1299 cells that were not changed to express ACE2, Omicron was not able to infect them. So let me quickly draw this as well. So here, let's say this is the original cell. And this is a common practice in research that they take a cell. So let's say this is the original cell. This cell does not have ACE2 on it. No ACE2 on it. That means if you put the virus next to this, then this virus, the one that needs ACE2, for example, Omicron or SARS-CoV-2, this Omicron cannot enter this cell because there are no ACE2 receptors. Then what they did was they also had another cell line, which is actually the same cells, but their genetic material has been changed, their DNA has been changed to be able to express ACE2 on them. And again, this is a common practice to change the cells to see what we are trying to do. So here is a cell, it has been changed to show ACE2 on its surface. And then when they bring Omicron next to this one, this Omicron is able to bind with it and infect it. Right? So go into the cell and make more baby Omicrons. So that is what they are seeing here. Omicron infected the ACE2 expressing cells in a concentration dependent manner, but did not infect the parental H1299 cells. So from here, they have established that Omicron needs ACE2 receptors to infect the cell. Good news. We knew this, they verified it. Now, we then tested the ability of plasma from BioNTech vaccinated study participants to neutralize Omicron versus ancestral D61G virus in live virus neutralization assay. So then what they did was they took, so let's say there were some participants, let's say you and me, we are vaccinated with Pfizer. I'm not vaccinated with Pfizer, with Moderna, but let's say for our examples, there are people who are vaccinated with Pfizer and they requested them to donate their plasma. So here is the plasma that is coming from the vaccinated people. So this is the plasma. Now the question is, of course, this plasma is supposed to have antibodies, correct? Antibodies that will bind to spike protein, correct? So this is the spike protein, and let's say one spike protein, and here another spike protein, and this antibody is able to bind with it. When antibody binds with the spike protein, it prevents the spike protein from binding to ACE2. That means it has neutralized it. So this is the neutralizing antibody, or NAB, neutralizing antibody. So these antibodies are present in this plasma. And as I just read this statement, we'll see further, but from this statement, now it seems to me that they are going to put in some samples the original ancestral SARS-CoV-2. Let's make it a little angry guy. Original SARS-CoV-2, against which this antibody was actually formed, or this vaccine was actually created. And then in some samples, some other test tubes, they will put Omicrons in them. I'll make the Omicrons, at least so far with the data, little happy guys. Maybe they'll become dangerous guys as we learn more about them. Good. So I'm going to call this ancestral E, and I'm going to call this O, Omicron. And they tried them as well, again in separate samples. Now, considering what study's title is, my understanding is that they're going to say now that, and we'll go and read it as well, but I'm kind of preparing. This is how I prepare myself as well. So I'm preparing you with me too. So they're going to say that ancestral virus was neutralized correctly, which means that the antibodies produced as a result of the vaccination were able to attack and bind to the virus against which these were built. Pfizer BioNTech vaccine was built against the original ancestral virus with the genetic material of that virus used. And I feel that they're going to say that this guy, Omicron, was not neutralized. The antibodies were not able to bind to this guy. And so this guy continued to stay viable. It continued to infect the cells. It continued to go in, become more, come out, and keep going. And that is the, I think, conclusion. From there, they would say that it seems like the antibodies against spike protein for the original ancestral virus are not able to work with the spike protein that is on the Omicron virus. And let's say Omicron virus is spike protein. I'm just going to make it for a shape change. Is changed like this. So this is so much of a change that these older antibodies are not able to bind with it. So in one way, we could look at this and become all worried to say, guys, we have an immune escape. We are doomed because this virus is now going to be the next SARS-CoV-3. Why? Because if the antibody cannot handle it from a vaccine, then our infection will not be able to handle it as well. That means the virus has phenotypically become so different. It has become so different from its functional and structural and appearance enough that the whole clinical scenario has changed. This will be SARS-CoV-3. Although, again, so far from the data point of view, the good news will be that SARS-CoV-3 is actually becoming more human friendly. Even when the study says it is really bad for the vaccine, it is still becoming better from data point of view. So if somebody walked up to me, for example, I saw Pfizer's message here. Pfizer did not miss a beat, and they came out and they said, preliminary lab studies demonstrate that 3 doses of the Pfizer BioNTech vaccine utilizing the Omicron variant, while 2 doses show significantly reduced neutralization titer. So they are actually, I think, are referring to this study. So look at their spin on it. They're saying, well, we heard that a study says 2 doses are not good, so 3 doses are good. Data indicate that a third dose of BioNTech increases the neutralizing antibody titers by 25-fold compared to 2 doses against the Omicron variant. And they are correct in saying this. What are they saying is, when you give another vaccine dose, it's going to ramp up the immune system and produce more of the antibodies. So when the antibody quantities are more, they're going to still attach to the virus and do a better job. So they're correct in saying it. But my hope was they would say well, we're going to go back to the lab and we're going to figure out a better one. Or maybe this virus is actually doing better in terms of not hurting us too much. So we would start seeing maybe 3 doses for more at risk and so on. So, meaning there would have been a more structured response. But this is their response. They said, okay, two are not working, take three. As 80% of epitopes in the spike protein recognized by CD8 T cells are not affected by mutations in the Omicron variant, two doses may still induce protection against severe disease. This is where they are correct, and I'll explain it what they mean here. I thought that they would skip this part just to be very sincere to themselves. But, anyways, they have actually given this one part, and I'll explain what they're saying over here. The companies continue to advance the development of a variant specific vaccine for Omicron and expect to have it available by March. Okay, so now let me explain this part as well, but let's go back to the study for a second. Now, the study folks continue and they say, we then tested the ability of plasma from BioNTech vaccinated study participants to neutralize Omicron versus ancestral virus in a live virus neutralization assay. We tested 14 plasma samples from 12 participants, with 6 having no previous record of SARS CoV 2 infection nor detectable nucleocapsid antibody indicative of a previous infection. So, this is again, I think that we all are aware of it. I'm just going to keep staying on the same page. And so that is, and I'll look at the questions in a second. What they're saying is there are 12 people, and they're all vaccinated. However, they wanted to rule out that they did not have previous infection. So, no previous infection, so that they can rule out the infection to the broader virus and more antibodies to more epitopes, just more than the spike protein. They wanted to rule that out so they can just focus on vaccines efficacy. So, how did they rule that out? They said, we looked at, so let's say here is the virus. I want to make the virus in red because it's a bad thing, the virus. So, here is the virus. And this is, let's say, the original virus or any SARS CoV 2 variant. When this variant would enter our body, this variant has spike protein on it. So, of course, there will be anti spike protein antibodies. So, please keep this in mind. So, there will be anti spike protein antibodies. Good. Now, these will also be present in vaccinated people because vaccinated people have spike protein as well. So that means just the presence of anti spike protein antibodies is not a proof that somebody had infection or vaccine. However, if somebody had the infection, then there are other proteins against which antibodies will be present. What are the other proteins? M protein, N protein. N protein is actually around the RNA. So inside the virus is the RNA. So here, this is the RNA. And this is our normal chemistry thing, that whenever there is DNA or RNA, it is usually protected with binding to some proteins. It's kind of wrapped around some proteins and bound. And not only, so these are histones, but this is not only that, it is kind of a protective cover, bony structure around this, just like we have a skull around our brain. This protein structure that is present with the RNA is called N protein. N protein. Now, you would agree that N protein is only present in the virus and not in the vaccine, or vaccine does not generate N protein. That means if you see in a person antibodies against N protein, then you would know that that person was infected at some point. So that is what they're saying, that hey, we made sure that the people that were participants, they did not have any proof of previous infection. They did not have any nucleocapsid proteins antibodies against them, and so they were truly vaccinated and their antibodies are because of the vaccine. Now, for two of these participants, we use samples from two time points. So that is why 12 people, 14 samples. The remaining 6 participants had a record of previous infection in the first CoV-2 infection wave in South Africa, where infection was to the ancestral virus. So there were 6 that had the previous infection as well. Now, so these samples had very strong neutralization for ancestral virus. So this is the first important clue here. They're saying, and this is what I was suspecting that they would say, and I just kind of said that here. They're saying that we have found that ancestral virus was strongly neutralized by the antibodies generated by the Pfizer protein, the Pfizer vaccine. So here they are proving that Pfizer vaccine is working as it should be for the variant for which it was built. Now, beta variant escape from, so let me actually read this part. GMT for the same samples was 32 for Omicron, a 41-fold decline. So when they looked at the titers and the avidity against Omicron of the same sample, that means the same antibodies produced by the same vaccine, that was working very well against the original virus. Against Omicron, it had 41-fold decline, 41 times less efficacious. Now, I know that Pfizer would come out and say, okay, take third dose or fourth dose or whatever is the next dose. But we had done this discussion in the past as well, that even with the infection with the same virus against which we have had the vaccine, or for example, if the vaccine was for the ancestral virus, Wuhan virus, we still had Delta virus properly um, targeted by these antibodies. However, the antibody titers reduce over time in general, and the body's response to the same vaccine generated antibodies response to the infection becomes less. And so it is a possibility that infection would occur. So this 41-fold decline is interesting. Why this is interesting here? Why can we not put it in that simple term to say, well, the efficacy had to drop at some point? The reason is that against the ancestral virus, the same titer is working, but against Omicron, it is working less. So that is how they are proving that there is escape. Beta variant escape from BioNTech in a live virus neutralization assay has been reported to be substantial. So they're talking about beta now. And our own data confirmed these results with about threefold reduction. So beta variant, threefold. Beta was the South African variant. The results we present here with Omicron show much more extensive escape. However, escape was incomplete in participants with higher FRNT50 due to previous infection. So, if somebody had previous infection and vaccination, their their antibody titers were better and they held up better. That's what they're saying here. Previous infection followed by vaccination or booster. So imagine if the two vaccines are previous infection and then there is a booster, or there is a infection and there is a vaccine, or there is an infection and a vaccine and a booster, or a vaccine and a booster, is likely to increase the neutralization level and likely confer protection from severe disease in Omicron infection. So really what they are talking about is not just that the antibody cannot bind at all. If antibody cannot bind at all, then you give a booster or you do whatever, the antibodies produced would still be not bindable and there will be no effect. But when they say that we believe that if you can ramp up the immune system with a booster, or if somebody had a previous infection, then they got vaccine, one dose, two dose. So infection, let's call it A, vaccine one dose, vaccine two dose. That means their immune system ramped up, ramped up, ramped up. And here it is against efficacious against Omicron. Do you know what that means? That means that Omicron has not really substantially escaped. It is why. If it has substantially escaped, then giving the same kind of antibodies will not help it because it would continue to escape. What they're saying is it has substantially escaped at lower titers, or at the titers where these antibodies, even in the lower quantity, are sufficient to handle original virus. In that quantity, they are not sufficient to handle Omicron. So, to handle Omicron, we need to have a greater quantity of antibodies. And that is what they would get by either a booster or if they had the infection and then the vaccine. That is how they're saying. Now, for me, if somebody came to me and they said, you know what, Omicron is doing this, and I have two Moderna. They come to me and they say, I want you to go quickly get a booster so you're protected. If I am at risk because, let's say, cancer, diabetes, uncontrolled, um, what is that, diabetes, or chemotherapies, or immunosuppression, either drugs or other reasons, then I would seriously consider it because I just want my immune system to stay ramped up so I do not have to fight with this thing. And my previous infection or my vaccines have just generally created less immune response, anyways. So having a third dose is not a bad thing. But if I am healthy and the Omicron seems to be weaker, more, let me call it more friendly, human friendly, then I would say that let me at least see some data. In the meantime, I'll protect myself. I will not go out. I will not mix with folks yet. I will do everything. I'll wear a mask. I know that many folks would say, why would you wear a mask? I would wear a mask. That is, I feel comfortable with that. I'll wear a mask. I'll do hygiene. I would stay 6 feet away. I would wash my hands. So I'll do everything, but I would want to just see, is Omicron really less dangerous? If it is less dangerous, then two doses may be fine for me. So that means it may not be just a very general response to say, everybody go get it. Now, this is the basic idea. You can see here is a study. Study has many important caveats. It's not a generalizable message. Here is the Pfizer's response. Okay, two doses not good, go get a third dose. And in some cases, they are correct. Now, I want to explain this last part and then we can do a chit chat. As 80% of epitope in the spike protein recognized by CD8 T cells are not affected by the mutation in the Omicron variant, two doses may still induce protection against severe disease. So, here is something that for me, when I was thinking aloud, that am I protected? Number one, am I protected? And number two, is Omicron going to keep us away from severe disease? So, let's see what they're talking about. We know that we have the innate arm, correct? And innate arm has dendritic cells here, dendritic cells, macrophages, the ones that are interesting for us, they're neutrophils and NK cells and others. But dendritic cells and macrophages are more interesting at this time. And we know that when they pick up the virus, then they would do what? They would activate the T helper cells So this is a T helper cell, right? It is wearing a t-shirt. I always think of them wearing a t-shirt. So this is a T helper 0 cell or naive T cell. And we've seen this diagram many times. We have, for 2 years, just been drawing these guys. So T helper 0. In the presence of um, interleukin 12, the T helper cells will convert to, they will become T helper 1. If there was interleukin 4 and no interleukin 12, then they will become T helper 2, which will go towards humoral pathway. But here, this is the T helper 1 pathway. T helper 1 pathway then in turn will cause cytotoxic T cells to become active. So this is a cytotoxic T cell. Let me see if I can make it really angry, because its job is to be angry guy. Its job is to kill other cells. Now, here is what they're talking about. What they're talking about is this cytotoxic T cell, or also called CD8 positive T cell. This T cell will not attack just willy-nilly any cell that is standing next to it. It is not on a stabbing spree. It doesn't have a knife in its hand and it's just going around stabbing whoever it sees. T cell have receptors as well. T cell receptors, TCRs. T helper cells have receptors too. These are called CD4 positive. CD4 positive. They also have receptors. This is the receptor with which they are bound. The free floating cells do not react in the immune system. Otherwise, we'll have a problem. Every cell would just become active. So here is a cytotoxic T cell. This cytotoxic T cell is standing next to an infected cell. So let's say this is some cell which is infected. It is crying. Why? Because it is infected. It has Omicrons in it, or it has, SARS-CoV-2, whatever, alpha, beta, some virus is present. And it is expressing that pieces of the virus on its surface on MHC1. This is called MHC1. Right? So now T cell receptor for the cytotoxic T cell has to bind with the antigen and an antigen presenting cell. Only then this T cell will kill this cell. So the T cell has to be the victim cell of the virus or the cancer. That victim cell has to actively bind with the T cell. That is an important signal for the T cell to say, you can kill this cell because you're holding an antigen it is expressing that it should not have expressed. And then when you pour, for example, interleukin 2 on it, when you pour interleukins on it, or when you give ready go signal to this cytotoxic T cell, and it is holding a victim cell or a sick cell, then this T cell would become active and it would start killing the cell by throwing perforins first, which would cause holes in the cell, and then it would throw granzymes, which are the proteins that would go into the cell and act like a time bomb over there. They would go and activate caspases. Caspases are proteins that would tell the cell to cause apoptosis or die. Now, I hope that this is clear that a T cell, cytotoxic T cell, will not kill a sick cell if it is not bound to it. That means this T cell receptor is a very important thing. Just like an antibody is important to bind with the spike protein, this T cell receptor is also important to bind with a sick cell's antigen presentation. Now, this antigen that is being presented is a piece of the virus. Now, what they're saying is, Pfizer, that when the virus appears in the body, it goes into a cell, the cell breaks it down, loads pieces of it onto the MHC1, major histocompatibility complex 1, and there are pieces of spike protein in there. The T cell that was trained by the vaccine is still able to connect with 80% avidity or with 80% recognition of the spike protein pieces, and is able to attack this cell. And they are saying this means there is a likelihood that severe disease would still not occur even when the antibodies are not able to connect as avidly. I shouldn't say not connect at all. So then there could be one last question here, and that is this true then that an antibody, at least this is the last question for me, it is true then that an antibody that is produced by a B cell or a plasma cell has a binding site for a virus that may be different from a T cell receptor's binding site for the same virus, or binding sites. One T cell would only have one binding site, but there are multiple T cells, there are millions of them. So the answer to that is yes. So even when the B cell is not able to produce antibodies that are able to successfully bind, T cell can continue to successfully bind. So one humoral section may not work as avidly while the cytotoxic section continues to work. Now, we have done another thing, one last corollary to this, and then we stop with this topic and we'll continue our discussion. And that is, we had done this discussion in the past that if the SARS-CoV-2 is managed primarily by the cytotoxic pathway, then the symptoms are fewer and long haul outcomes are fewer as well. It is the humoral side which, when becomes active, the B cell, the plasma cell side, and produces antibodies, which then causes the cytokine storm to occur, that the patient can become more, some patients, not all, can have a severe outcome, and some can become long haul as well. So maybe there is just one more good thing that happened. Now, this is my opinion part. Can be discarded, thrown away, told that Mobeen, you're wrong. And that is, maybe there is one more good thing that has happened, that even in the presence of vaccines or previous infections, the pathway that is primarily engaging is cytotoxic pathway, because the humoral pathway is becoming less effective. And that causes better outcome for the patient because it does not lead to cytokine storms, and patient is still able to handle the virus. If this is the case, I will be so happy that I was the one who discussed this mechanism over here first. But this is what can happen. Now, I hope I made sense without any preparation. And now let's just see if there is anything more in that study. Okay, so then they have material and method. So this is the study. Now, how about questions? Mike says, wow. So, Mike, what did you like? Tell me. JG2 says, do you recommend mRNA booster? So, I got mRNA. I like mRNAs. And the booster is really a discussion between you and your doctor. I have actually never sat here and recommended or was against vaccines. I always gave my own example. I am vaccinated with Moderna, 2 doses. I feel I do not need a booster at this time. My wife has 1 dose Johnson and Johnson. She has had reactions to them even to this date after 6-7 months. My older son, 28 years, has Pfizer 2 doses. My younger son, 24 years, has Moderna 2 doses. So we all believe in vaccines, and this is what we have done. Your decision is your decision, because I have no idea. I actually find it wrong when journalists, doctors, people just in general come in and some say we should get vaccinated and others say we should not get vaccinated. How can we give a generalized statement to situations where things and decisions have to be case by case? Good question. Alberto says, are you related to Mr. Bean? No. So Michelle says, shame he wasn't prepared. Thank you, Michelle. Okay. So where is Luffy? Luffy had done something bad today. He peed again at the door, and that is when he wants to go out. And if somebody doesn't open the door, he just pees there. So Luffy has been allowed to go out, and he's been out like a brat for the whole day. So Luffy is a handful. I really like him though. So Mike Gardner. So please, for the questions, I cannot give a personal advice, and I should not give a personal advice. It's just not correct. I got Pfizer, which seems to be inferior to Moderna. Should I boost with Moderna? Look, I like Moderna more for myself. I'm not a big fan of Pfizer, but at the same time, Pfizer, almost all Israel has had Pfizer, and there have been very good results there. I think Pfizer did something. My opinion is that it was greed. Maybe it was not. And that is that they kept saying our vaccine efficacy goes down, our vaccine wanes, the antibodies wanes, we should go for boosters. I think they just wanted to give boosters and earn even more money. I may be wrong. In that process, they tainted their own product's brand. Doug says you rewarded his P. Yeah, because if we don't, then he will continue to do it. And cleaning pee is a problem. So today it was my turn to clean it, and it's not fun thing. So he can go have as many fun times as he wants outside. Barbara says you have incredible intuition. Thank you, Barbara. um, so there is a question which I really cannot answer. So Dr. Bean, is it better to get natural immunity or vaccine for healthy people under 30 years of age? I would not recommend natural immunity to anyone. I hear Lufir Kairi, to anyone, because there is a chance that it can kill a person. There is a chance, although with the vaccine there are chances as well, but frequency and the chances are different. The long COVID can be possible as well. So does that mean I'm pushing vaccine? No, that simply means I cannot say to someone at all to go get infected. I have been saying it for 2 years, that 2 years, 1.5 year, that this cannot never be suggested to go get infected. We will see how Omicron does. If it does the way it is, we may have a more human friendly virus. And I hope it stays that way and it becomes even more friendly. And that would be awesome. If it just becomes a human virus and goes through the population, gives them immunity, and we're good. But it still is causing deaths. Gift says, get out the water pistol for Luffy. Yeah, so he doesn't get it that he got water sprayed because he peed or something. When he wants to go out, I wanted to make a video and show you. He would jump up the table and down, and then jump up on the door and down, and he would run in circles till you open the door for him. He becomes so anxious to go out. MCAT says, are you using enzymes? Yes. So that is why it is such a hassle, that you have to dry it, then you have to use various enzymes. I use soap as well. So first you use soap. So we have a wooden floor, but still, first you use soap, then you use enzymes, then you uh, wash it all out, then you spray um, the deodorants, and it's a project. Texas says, Dr. Bean in the doghouse, yes. Barbara says, we love Luffy. Yeah, we love Luffy too. Gift says, sounds like Luffy's vindictive. He will pee if you don't open the door. So Ali G says, which variant is going to dominate, Omicron or Delta? UK, Great Britain, doctor said Omicron is not causing serious symptoms. Why patients are still dying from Omicron friendly virus? Good question. First, so far from the data, it seems like Omicron is going to win over Delta. And there has been a lot of questions that why. I did a discussion about how it becomes dominant, but there still seem to be some confusion. So if there is a confusion, please write it down and I can try to answer that. It seems like Omicron will win over Delta. That's one. Number two. Yes, compared to Delta, Omicron's behavior is milder. For example, I was listening to this Minnesota man who had um, who was the first person with Omicron in the US. And he said in his interview, he said, I felt like I had cold and I was tired and fatigued for one day and I was fine the next day. So if that is a kind of situation, then it is good. But if you look at the data that is coming out of South Africa, the study that or they call it crude analysis of the first few data sets, there still were deaths because of the COVID. Very less compared to Delta. First, less cases compared to Delta. I'll back up. More cases because of Delta compared to Delta, but less hospitalizations and less ICU and less deaths. But still deaths. It is much, much better than Delta so far from the data. We'll see if it holds up that way, LEG. Mike says, you think that's bad? My cat pisses and my boss is general when arrives in morning. Carol says, bad Luffy. SJ says, I have Pfizer. Well, you must be rich. So Brian K says, for someone in the resting phase and thus more prone to lesser viral load causing infection, does the 41-fold antibody reduction mean an extended time to respond with the cytotoxic side? No, so the cytotoxic side would still respond fast enough because the reduction is on this pathway. And then the reduction is not even to the speed, the reduction is the quality of this product. However, this connection here is working fast as it was, I'm assuming at least, otherwise they would have caught it. And then this connection becoming T helper 2, this would just be presence of the interleukin 4 and absence of interleukin 12. So that has nothing to do with the antibody production. And then IL 4 and 5 production, that is also going to be the function of this T helper cell. So it is really this guy when the plasma cell, the active B cell, when this guy works, the product is not as efficacious, but this pathway works in the same with the same speed. Good question. But I'm hearing that the incubation time is more. So that may be because the humoral side is not kicking in. So there are two boxers that come in and help beat the virus, humoral side of the antibodies and the cytotoxic side or the cells. And here one side is coming in weak. And that probably is helping the patient having less symptoms. That is also helping patients from against the severe COVID, hopefully also against the long COVID, and it is allowing the cytotoxic side to slowly take care of the cell. Cytotoxic side's function is rather, compared to humoral side, is slower because T cell has to bind with a cell that is sick and then kill it, while the antibodies can just be sprayed in the body and they would go in the tissues and the blood and they would just run around everywhere. So compared to that, uh, T cell are slower. Whatever this combination came together, our immune system's behavior, the virus's behavior, that whole thing so far looks like it is working. So why not we look at it? Let's look at data as well. So I had some data put together here. Where is my mouse cursor? So this is drbeen.com. You can go buy a plan there. So here, this is the number of cases. So number of cases, look how high they have gone. Uh, we have 11,881. A few days ago, we were at a few hundreds. So November 15, 286. And now November remaining 15 days and 8 days, 3 weeks now. And we are at 11,881 in one day. So that's a lot of cases. Although this is 3 weeks, so I think the severity and hospitalization and deaths should also be, we can start trusting some of that data. And here is the data for deaths. Still unfortunate that there are people dying. They are they are universes in themselves. They have families. They are like you and I. So it is sad. But look at this. Today, 2022. So if we go back to November, of course, November 15 will be 4 to 6 weeks indication of previous time. But here, for example, let's say we take today's time, December 7. Let's say 3 weeks earlier. That is about middle of November. So that is, in my opinion, an indicator of what is going on. And it shows lesser number of deaths. Oh, thank you very much. Um, Benjamin says, eventually, if we determine Omicron is like influenza, do we still need to make vaccine mandatory? Will the largest human field test for the vaccine stop? So, I generally am not a big fan of mandatory vaccine. Um, but to me, it seems like, now I'm going to say something that is going to get me a lot of wrath. To me, it seems like folks who are not yet vaccinated, the virus that is facing them is milder. And that is a good thing. I mean, they're not vaccinated for whatever reason. Still, virus, if it is continuing to become friendlier, then that is a good thing. So, says, wouldn't an infection with Omicron produce enough immunity against further Omicron infections and all other coronaviruses? Ideally, yes. But see, Delta was supposed to do that too, and Alpha was supposed to do that too, and Beta as well. So viruses continue to mutate. Plus, this infection has not gone into everybody yet. So If it becomes more and more humanized, that simply means it is when it infects us, we would not have too serious an outcome. But it is still a very transmissible. See, it is becoming more transmissible. It's going to go to everyone. So James says, should anyone morbidly obese get a booster? Thoughts also on mixing vaccines. So I like mixing vaccines. They actually provide better result. And yes, anybody at risk should consider a booster. I cannot ask them to go do that, but I would recommend to talk with the doctor and consider it. So Sally says, is it wise to get shots for a virus that is asymptomatic to mild in symptoms? The question is that we don't have this guarantee that who will it be mild for and who will it be asymptomatic for versus who will it kill. So as long as we are able to determine that, then it could actually be seen this way. MCAT says, can you look at study for natokinase benefit during cove? Sure. You'll have to send it to me in Discord or Twitter so I can work on it. Druman says, if the booster dose is the same as 1 and 2, how is efficacy boosted over 72% for Omicron, just the number of antibodies being produced? It's actually what happens is, let's talk about this. This is a good question. What does a booster or a re-exposure does? And please know that it's not necessary that every time a re-exposure occurs, we become better. For example, we get strep infection and we get it again and we get it again, we get common cold. So it's not necessary that every time booster would make us better forever. But generally, what happens is, let's say this is exposure one. Exposure one. As a result of this exposure, body would end up making some memory cells, right? So these are the memory cells. They're sitting there kind of, they're really not sleeping. It's just that they are able to handle this virus fast because they have been asked to live longer and stay. So they are actually working, they're making small, tiny antibodies. They are sitting in a bone marrow or circulating in the blood or sitting in the local lymph nodes where the infection of the vaccine was. So they're there. They're not actually sleeping like we sleep. But we call them memory cell, and I call them sleeping because they're not really making more babies of themselves and so on. Now imagine that first exposure created 1 million. I'm making up numbers. This is not exact number. Makes 1 million B cell memory cells. Normally they are lesser than that, but let's go with this. Similarly, another 100,000 T cells and so on. So there are a bunch of stowaway cells, storage cells, um, cells to be kept alive. Other cells are asked to die. Then let's say there is another exposure. Exposure number two. Exposure number two would trigger these guys that were already sitting there saying, is there this antigen here? These guys will become exposed to the antigen that came back right away and they would become active. And what does that mean? Number one, they'll make copies of themselves. Number two, they would become affinity matured. Affinity maturation means that they will learn from this antigen that came back to them. They would learn further how to bind to it more successfully. So they would learn to bind more hard, more better, more tightly with its antigens. That is called affinity maturation. Maturation. So one, there are more number of cells produced, and then secondly, they are better in in binding with the antigen. So can I say that these cells that are now produced are more expert in killing this thing compared to this first batch? Now imagine that these cells come in, they make antibodies or they make cytotoxic activity, and then the infection goes away and they die again. But another few will go into the memory pool, and they are actually more expert as well. So now imagine if previously there were million and 100,000, so 1.1 million, you may have added to the memory pool, to the sitting pool, another million cells. And when you have added more cells to this, these cells are actually more expert as well because they've done affinity maturation. So this pool of responders, first responders, has increased from point A to point B. So you can see that on point A, we had lesser number of people. You can see in my diagram this, and you can trust that this happens in the body as well. So here is the, now imagine there is a third exposure. So you can now extrapolate what would happen. With the third exposure, these guys who are sitting there, once again, they will become active and they will make another bunch of cells. They will do more affinity maturation and they would keep becoming more and more expert and so on. So with every exposure, the immune system would become better, would learn more, will increase the pool of memory cells, will become better ready for the future. That is how boosters or exposures work. Thank you very much for the super stickers. Aliji says, can we differentiate how many cases of Delta in a country and how many Omicron cases? Will treatment protocol remain the same? So far the treatment protocols are the same. Remember, I was thinking aloud a few days ago that maybe some more of TMPRSS2 blockers may be needed to reduce the speed of the virus interaction with us. Mostly it is the same because it just comes in and goes away so fast. Having said that, and it's not in all cases, but in more cases, general cases. Now, the question that how many cases of Delta, so sequencing would tell us Delta versus Omicron. I do not know if the countries are actually doing that a lot at this time, or maybe they're producing this data, some of the countries, and we don't have that yet. I would suspect countries like UK and Israel may be doing it. I'm not super confident for US. I feel South Africa would be doing it as well. So maybe we'll see that data soon. And please, the discussions that I do over here and the drugs I talk about, these are not an advice. This is just a medical educational channel, information channel, maybe a little bit of entertainment as well with these fun cartoons. So Lahar Butter says, a lot of long haulers, including myself, are feeling better after getting the monoclonal antibodies for long COVID. Any explanation as to why the monoclonal antibodies are helping long haulers? That is a very interesting situation. And I have not read any studies. So that means what I'm saying here is going to be totally throwable concept. And that is, remember one reason. So, long hauler, we have done this discussion many, many times. One reason of the long hauler symptom that Dr. Bruce Patterson and Dr. Yo have been talking about is the monocyte holding on to the S1 proteins. Now, if they are holding on to the S1 proteins, remember monocytes are parents for macrophages. So, one, they create the cytokines. Secondly, it is possible that they can start presenting these as well which means that the immune system can become active against them, and that causes these symptoms. Now, if we have antibodies, it is possible that these antibodies will bind to these S1 pieces that are being expressed on the monocyte surfaces. Or if a monocyte is broken down and the S1 pieces are removed, possibly antibodies could be connecting and wiping them off instead of another monocyte or macrophage eating them up. And so that may be one way that this is being helped. DC says monoclonal antibody is effective for Omicron. In theory, yes, but monoclonal have a bigger problem. Monoclonal are one antibody. So we have to wait for their companies to tell us that were their monoclonal antibodies binding to some part on the spike protein which has become more mutated. If so, then they will not work. But I haven't yet heard anything from these companies. Zikaz says, I tweeted you the study secreted or open reading frame 8 is a pathogenic cause of severe COVID 19 and potentially targetable with select NLRP3 inhibitors. I have not discussed it. Can you please maybe resurface that? I have not been looking at Twitter for some days and nothing because I was just stuck in another complaint issue. Sheila Clark says, Dr. Bean looks so handsome today. Thank you. Bubble Rapper says, we're getting a lot more cardiac and neuro admissions. There are side effects. Butterfly Kiss has a very good question. Do memory cells get old and die out or reproduce themselves? Memory cells tend to reproduce themselves as well to keep a basic level going. And I think that this is a complex mechanism. There is a lot of research to figure out how, but it seems like the antibodies that they produce or the antigens against which they work, they can check their own activity, and then if that activity is low, they can increase in number, so they can keep that balance. However, you know that memory cells are not, for every case they're not the same in duration. Some diseases create memory cells for lesser duration because these memory cells do not go in the bone marrow. They just live in the lymph nodes, or they live in the circulation or the local tissues. There, their life is less. They die out. If they go to bone marrow, then they can live there for decades. But the thing is, we cannot stash every memory cell in a bone marrow. Imagine we'll just fill the bone marrows with trash. So there is a complex mechanism to allow some memory cells to go to bone marrow. Interestingly, both vaccine generated memory cells and COVID disease generated memory cells go to the bone marrow. So ideally, there should be a long term immunity, which is a good thing. I hope I'm not wasting your time today. I was totally unprepared, and my apologies. Memory cells. MEMORY. I may have an accent, but memory cells. Check this out, memory cells. So Skyfrog says short term and long term memory cells. Yes. So there can be memory cells, for example, in the local lymph nodes that might go away in months to years. The one that live in the bone marrow are known to be there for 20 years later, 30 years later, sometimes lifetime. Columbia Bean says, I'm going to go take rest. Thank you, Columbia Bean. Take rest. Then simple tests for checking memory cells. So we know that memory T cell can be checked. That is the T detect test. I do not know if there is anything for memory B cells other than looking for antibody titers. Texas says, have you heard of the stealth Omicron subvariant that is evading PCR testing? So I knew that the Omicron itself was evading some PCR tests. I did not know that the subvariant is evading more. So that means it is failing more than one signals. No, I did not. I'll look into that. I think you may have a link on Discord. Is it possible if you can send me that link in the DM of the Discord so I don't have to look through the chain of links? So Gurang says Omicron will be dangerous for children below 5. I think all SARS-CoV-2s have been less dangerous for children under 9 years of age, a little more dangerous to under 1 year of age. However, this data, remember they said more children in hospital under 5 years of age. At the same time, they also said that that was out of abundance of caution. There is no death in that age group, and so on. So data is not clear to be able to say yes or no, but from the behavior of the virus in the data so far, it does not seem like dangerous. But please don't hold me to account there because we need more data. Acadian Acadian Hoon says, have anyone tried to scan if vaccinated emit early Bluetooth signal? That'll be so nice. If I could emit a Bluetooth signal and turn on things off and on, that would be awesome. Gold Country said, where and how is Jana? I don't know. She used to be here sometimes. I hope she's doing well. Carol says, why are all studies Pfizer? How is J&J holding up? That is a good question. I think J&J's efficacy drops faster, but still there are less studies with J&J. So, what are the ages or comorbidities of the? So we had data that children did not have deaths in them, but they did not give exact age and comorbidities. They said in adults vaccinated and unvaccinated, mostly unvaccinated, but too small the data sample. So we need some more data. All right. So what are more questions? Sorry, I was just Rima's here. Do we know anything more about how lethal Omicron is? I can't wait for it to be over as I simply cannot pronounce the blasted. Oh, so basically it is impossible that I'm teaching pronunciation because I do not know to pronounce things by myself and I have an accent too. But it is actually Omicron. So it is small o. So Omicron or Omicron. So some people are calling it Omicron and some are calling it Omicron. Ideally, if it is Omicron, if it is Macron, then it becomes big O. It is actually a small o, so Omicron. So Omicron. Jody says, can we have Dr. Heather on as a guest? I had actually reached out to him, and his brother, in a very tactful way, declined. So I think Dr. Heather, like me, has been under some targets as well. and maybe a little um, less available at this time? I would ask him anyways. Kelly says, I'm trying to not laugh out loud because my husband is back from his quarantine in the basement, but this chat is cracking me up. So laugh out loud. Let him wake up. Ray says Omicron is not lethal. It has been out for a month and no deaths data. No, that is not correct. We looked at the data a couple of days ago, and it does have deaths because of COVID. The numbers are low, so we can say it is much better than Delta, but it still is causing deaths. So, Rima, we all started talking about the pronunciation. I didn't answer your actual question. Hopefully, it would go away soon. At least the signs are good. So, Doug says, are we going to look at other countries? Yes, tell me. Doug, please tell me what countries. So, this is South Africa. I had uh, UK here as well. So, UK cases are again increasing. What happens with UK that their cases just continue to go up? Why does this happen with UK? I don't know, but there is a good news, and that is the number of deaths are really low, which is good thing. They have risen up again since June, but they are still relative to where they were. These are low. So that is UK. Tell me more. Which country? I was actually curious about Israel as well. So I had Israel's dashboard open. So if I go here, I think this is the dashboard. This is Israel's dashboard. And let me see if I can. First, I have to go back to normal size. So here, severely ill, that number, unvaccinated, vaccinated, and vaccinated 0.4. What I do not know is that the vaccinated here means 2 or 3 doses. I just opened it up in front of you. And unvaccinated 26.2 per 100,000 over the age of 60. And then vaccinated without validity, which may be 2 dose, 7.5. And vaccinated, the third line may be 3 dose vaccinated, 0.4. Um, what I am usually curious for the data from Israel is the number of deaths and the R naught. So if you can look at that, I think this is the R naught. So their R naught has risen to 1.08. So they've been at 1 for a long time, which is excellent. And then pediatric morbidity is less, which is good. I saw, is this the died daily last month? Average age, passed away, died daily, immunization status. So here, if for example I go to Monday 6, they're all 0. So let's go to some vaccinated, not vaccinated, died 0, vaccinated without validity, maybe 2 dose 0, 3 dose 0.1. Then here, this seems to be unvaccinated 1.7 and the other 0. So interesting. Generally, 4.2 here on 19/11. So that is November 19. So good results in Israel. So that is another country I was curious about. Uh, so WC says, what is the question? WC's question, there was a question, how come some people get myocarditis after vaccine? So I have done lots of discussions about it. The basic problem, and I think eventually I was proven correct, it is the molecular mimicry, and that is that antibodies attack our tissue thinking it is spike protein, or it looks like spike protein. So Lee Williams says, did the people who died from Omicron or did they die with Omicron? So the data that we presented, that was from the South Africa's some medical agency. They had said this is not a exhaustive data amount because the numbers were small. The deaths that they said were categorized in two ways: those who died for other reasons than COVID, but were incidentally found to have COVID as well when they were in the hospital, and those who were COVID infected and died of COVID. So they had put them both. All right. So, okay. So Doug says Zimbabwe. Zimbabwe, where Jackie Stone is, you should have her on. Okay. So let's see. Zimbabwe. Okay. I think I tried to reach out to Jackie and I could not find her, meaning I could not have her contact to reach. Okay. So here is Zimbabwe. Daily new confirmed cases, very few. Alexa, what is the population of Zimbabwe?
In 2020, the population of Zimbabwe was 14.9 million people.
Okay, so 14.9 million, and they have 996 cases. And if you see here, these are increasing. There used to be, for example, November 29, there used to be 43 per day. From 43 per day, they are now about 1,000 per day. So that's 20 times increase, correct? Or 40 times increase. And then let's see the number of deaths. So 0.71 moving average, 7 days moving average. So almost no deaths, which is good, or very low number. And they have been staying low since September, October. So very good numbers for Zimbabwe, Doug. My apologies, you must be listening to my mouse as well. My mic is sitting very close to the mouse today. Bambi says, hey Bambi, how are you? How is UK? Why do UK keep getting so many cases? Now many government staff broke the rules a year ago. I fear many will rebel and not follow NPI restrictions. My prediction that by Christmas the Omicron will be dominant and unvaccinated in hospital. I see. So JMT says Ireland. So let me start Ireland, and I wanted to see, there was a super chat. I want to go and check that as well. So Sheila, thank you very much. And Anthony Di Stefano, Thank you, Dr. Bean. Why do some have myocarditis and others don't? The more boosters, the more risk grows of myocarditis. So very good question, and I'll answer that. Let's quickly. I'm gonna leave this question here so I don't forget it, and I'll see if I can. So this is the Ireland. So Ireland 7.86 moving average for deaths. They were actually they have been low since April of 2021, and they have stayed low. There was a tiny bump here. So they went, for example, from 3 and 2 and like that to 2.29 to 9 or 10, and then they dropped again to 6. So about 2 to 3 times increase in deaths, but still, Alexa, what is Ireland's population?
In 2020, the population of Ireland was 4.94 million people.
Okay, so the number of people are less as well. And now, if we go for the cases, here, cases are higher than Zimbabwe. So they increased in cases since October 8. They started increasing then October 29 or end of October, their numbers were increasing a lot. And then since November, they are totally high. So Ireland case numbers are high. What I don't know is the per million. So if I go to see per million, is this per million? No. This is cases per million. So if I go to here, this is cases per million. Ireland's cases per million are higher than South Africa and Zimbabwe. Why? 934 cases per million, South Africa 197, Zimbabwe 66. What's going on with Ireland? We should see more. Okay, so let me answer this question. Why do some have myocarditis and others don't? So the answer is actually very simple. The B cells that we have, my B cells, your B cells, somebody else's B cells, all of our B cells make the antibodies that have the binding regions, but they are randomly generated. Very few of our B cells would have exactly the same binding regions. Because of that, even when they can attach to the same pathogen, so let's say this is a pathogen. Let's actually make SARS-CoV-2 here for our.
Sorry, I don't know that.
So let's say this is a SARS-CoV-2 spike protein. We'll make it dangerous thing. A little angry guy. Okay, so that is SARS-CoV-2. Now, here, this is a spike protein, and spike protein has hundreds of epitopes on it. That means patrons. These patrons are 7 amino acid long. Good. And so there are hundreds of those patrons. Now, it is not necessary that all of us for sure have the same B cell binding system that would bind to the same. It is possible that we'll have similar binding sites, but we all have some difference. Just like our face is different, similarly, our B cells and the binding site, and our T cells and the binding sites that are on our antibodies or receptors are different. And they're produced randomly by shuffling genetic material. Because of that, it is possible that in some people, they look at this antibody and they look at this pattern, let's say, and here, let's say, on the I said antibody, antigen. So let's say this antigen, spike protein, has a pattern here that looks like our cardiac tissue. However, in, let's say, most of the people, we don't create an antibody that binds here. And because we don't create an antibody that binds here, that antibody doesn't bind to our cardiac tissue as well. That is one possibility. The other possibility is maybe we produce it, but our immune system knows that this is a site that is looking like our tissue and knows to not attack our tissue. It is self tolerant. It has energy, energy. And so it says, oh, well, even when I see that there is a problem here, I'm able to bind here, I'm not going to create a reaction to this. So maybe in some people, just like they have autoimmune diseases, in some people they do end up creating a response. And then a tiny bit more complex situation is this, that imagine if you have a tissue. Let me do it this way. I have to come up with an example on the fly. Imagine there is a page here that says HO, and then there is another page here that says ME. And when you put them together, they say home. Similarly, it is possible that sometimes an external antigen, for example, let's continue to use spike protein as our example. This is a spike protein. Let's say three epitopes here, and this spike protein is sitting next to cardiac tissue, which generally doesn't go there. But let's use this as an example. Let's say it is sitting next to a cardiac, heart, muscle tissue. I'm trying to make a branching muscle which is near here as well. So here, cardiac tissue is branched muscles. And here there are four epitopes. And together they look like a binding site for a valid B cell. And now the B cells start making things against this area. And now we have a problem. So there are many ways that an immune system can become triggered by the presence of a virus against the cardiac tissue. There are other viruses as well that are known to cause directly attack on the heart or molecular mimicry resulting in antibodies production for heart. Gift says the mouse needs some cheese. Yeah, I need to change this mouse. It is too noisy. And my keyboard as well. Yes. Yes. That has to be on the Odyssey channel. So this question, Joshua says, how can they test for specific variants when they can hardly test for the virus? They run up to 50 cycles and death with COVID are counted. Is it real or all just an agenda? So I'll leave the last part of the question. And the first part, that how can they test for the variants? They can. So I was actually, many people had been asking me this. Many folks had been saying that, how is it? Actually, there was one comment that stuck to me where they said that it is such a tiny virus that you cannot even see this under many microscopes or other such systems, and you are still getting in there and looking at RNA and saying what kind of RNA sequence it is. So I thought it would be interesting. It is actually a very simple mechanism to sequence it, but I thought it may be interesting. 23andMe does sequencing as well. So sequencing is not a very difficult or high tech anymore. So maybe, Joshua, I would take that up as a separate talk and discuss how sequencing is done. Kirk says, with the prevalence of at home tests, do you think we should only count hospitalization versus cases? It seems like a significant amount of cases will be underreported. That is correct. For example, the gentleman who had the Omicron, or who was identified as the first case of Omicron in the US, they said that, were you worried about the COVID? And he said that I was not going to do the testing, but then uh, COVID center, someone contacted them, and from there on they kept going. So it looks like he would have just left it as, hey, I had common cold. If I became sick today and tomorrow I'm fine, I would just ignore it. So although I know that I'll go and do the testing, my son was here during, I think, my wife's birthday's time in November, and he felt he was congested, and I ran and I brought the test and quickly did it. But generally, you're correct. I think hospital admissions because of COVID, ICUs, deaths, that is a more important data point. So I hope I did not do anything to waste your time today because I was not prepared. With this, let's answer one more question and then stop. Um, can you do me a favor? Can you please like, subscribe, and share? Although it is 1 hour 38 minutes. And if you would like to support this work and not just the COVID work, if future work as well for medical students, nursing students, for healthcare professionals, I think that this education is useful for them as well. Very useful. You can support this work. You can be a patron, you can buy me a coffee, or you can use PayPal. So let's see one more question and then we stop. Kirk says, with the prevalence of at home tests, so we just answered that one. Kirk, uh, let's take one more. Ali G says, is Pfizer better as booster or Moderna for 40-year-old woman who has received 2 doses of AstraZeneca? So, you know that I cannot generalize this thing. I like both Pfizer and Moderna. If somebody gives me a choice to say what would you like for yourself or your wife? For example, my wife had Johnson and Johnson. I don't want her to take Johnson and Johnson anymore. Her side effects are still continuing. So I said if it becomes mandatory that we have to have a booster, then take Moderna. Pfizer has been low dose, so the side effects and the intensity was lower than Moderna. So Pfizer has its own benefits, and I had done that discussion in the past as well. So with this, thank you very much, everyone. Um, please have a nice evening. Enjoy. Like, subscribe, and share. Links in the description. I will see you tomorrow. Bye bye. And apologies for the prepared lecture not being there today.